Thanks for the invitation to talk today. My name's Philip George. I'm a consultant haematologist in Wellington. And I'm going to talk to you about supportive care in B-cell malignancies today, mainly focusing on myeloma and CLL. So I'm going to discuss largely talking about infectious complications and supportive care in terms of reducing the risk of infection in B-cell cancers in particular. We're going to talk about some different trials that have been carried out in the setting of both myeloma and CLL, which are looking at reducing the risk of infections in these blood cancers. We're going to look at the new area of immunotherapy and how that's influencing infection risk as well, and a case study from Wellington to illustrate some of those points. Also going to look at the role of vaccinations in B-cell cancers. And finally, at the end, we're going to discuss briefly watch and wait in B-cell cancers, particularly CLL as well. We'll have some questions at the end. So we know that in myeloma, infections are a substantial cause of death. And we know that overall, if you look at people with myeloma compared to age-matched controls, we know that people with myeloma are about 7 times more likely to have significant infection, bacterial infections. And in the first year, that actually increases to 11 times compared to age-matched control. So significantly increased risk of infections, and even more so with viral infections, where you have a 10-fold increased risk, and then 17-fold in the first year of diagnosis. This data is actually reasonably old now. This is from sort of the early 2000s, from a Swedish cancer registry. And also you can see that out of deaths that occurred in the first year with myeloma, almost a quarter of them were infection related, and that is actually getting more as time goes on, probably because the treatments we have are getting better, but they can be more immunosuppressive as well. So infection is becoming a really important topic in this area. We know there are multiple reasons why patients with myeloma may be at an increased risk of infection. We know that the myeloma cells, the plasma cells, they make antibodies, and those antibodies are really important for providing immune response to bacteria and viruses, etc. And we know that other parts of the immune system as well are affected by in myeloma and reduced and impaired other aspects such as dendritic cells, which are very important at allowing our T cell system to fight infections, and other cells such as neutrophils, which are the healthy white blood cells in the blood, which help to fight bacterial infection. And we know that there are different factors for patients that put them at higher risk of infection. We know that factors such as nutritional status, other medical conditions can also contribute to the risk of infection. There's some data from the first trial, which was a trial in myeloma looking at patients that weren't able to go on to a stem cell transplant, but were managed with chemotherapy alone. And there was some data that found there are particular factors which increase the risk of infection. So ECOG performance status, some blood tests called beta-2 microglobulin and LDH, and also the hemoglobin, the red blood cell concentration. All of those things actually are contributory to infection and can predict potentially how likely a patient is to have infection. We know that the different treatments that we give for myeloma also can increase infection risk, and we need to often give medications to help protect against infections when we're using a lot of these agents. Many of you will be familiar with these sorts of agents. So dexamethasone, which is a steroid tablet, which is used in a lot of blood cancers, is an independent risk factor for infection. And there's a particular infection called pneumocystis, or PJP, in which patients with myeloma and other conditions are increased risk of, and steroids like dexamethasone are a risk for that. Proteasome inhibitors like bortezomib, we know that they increase the risk of viral infections such as herpes zoster, and we always give patients antiviral medication to lower that risk of infection. Other drugs such as lenalidomide can lead to low neutrophil counts. So sometimes we have to support those neutrophil counts with other medications to boost them up. And then newer agents such as monoclonal antibodies. You may have heard of daratumumab. Unfortunately, it's not funded in New Zealand at the moment, but we know that that also can contribute to infection risk. And I'm going to talk to some of the newer therapies in myeloma a bit later in the talk as well. And in CLL, again, it's a fairly similar sort of story. We know that CLL is a cancer of the B cells at a slightly different stage to the myeloma cells, but equally infection is a problem in patients with CLL. This is some data from Denmark in a CLL registry, and it looked at patients between 2008 and 2016, and they found almost 3,000 patients diagnosed with CLL during this time. And over a third of those patients either had a severe infection, started treatment, or sadly died within in the follow-up period. And around 660 patients there actually had an infection before having treatment. So we know that infections, even in patients where we don't necessarily need to treat the CLL at that time, infection still can be a big problem. And actually the incidence of infection within 1 year of diagnosis was actually about 12%, and the infection following treatment was about 11%. So actually, even without treatment, we know the risk of infection is quite high. And unfortunately, there is a mortality associated with that infection, as you can see. And in patients with a severe infection, up to a quarter of patients can die within a year of that severe infection. So it's really important that we can recognize and try and reduce that risk as far as possible. You can see here that this is the survival curves for patients with CLL who are having infection problems versus those that aren't having infection problems. And you can see that unfortunately the survival does reduce in the patients who have been having severe infections compared to those that aren't having infections. Back to myeloma again, and we can see that early death within 60. This is data from the UK actually, and this is looking at data collected from clinical trials, again predominantly in the 1990s and early 2000s, and they found that for deaths that occurred early on in treatment, i.e. within 60 days, infection was the leading cause of death in those patients, and bacterial infection was the direct cause of early mortality in 45% of deaths, pneumonia being the most common cause of death in that group. So we know that infection is a problem, and actually as the treatments get better at treating the underlying disease, infection can be a more major issue that we have to deal with. So looking at what we can do about infection, well, there have been some clinical trials in this setting, and there are more taking place in the future. This was a trial conducted in the UK. It was conducted between about 2015 sort of time. And this was a phase 3 trial, and it was randomizing patients between an antibiotic called levofloxacin or placebo. And these were patients with newly diagnosed myeloma. And patients were either given, you can see 500 milligrams of levofloxacin, or they were given a placebo tablet daily. And that was given for 12 weeks when they started treatment. And patients didn't know whether they had levofloxacin or placebo. And the outcome they were looking at this trial was looking at time to the first febrile episode, so first time they had a fever, or to dying from all causes within 12 weeks of trial treatment. This is the sort of baseline characteristics from the patients, and this is a consort diagram. You can see patients here, so 977 patients randomly assigned, equal numbers really between levofloxacin, the antibiotic, and placebo. And you can see here, these are some of the features of the patients, and as I say, a fairly even split between the antibiotic group and the placebo group. And what they found is the trial did meet the primary endpoint, and that endpoint was having a fever or death up to 12 weeks. And you can see that levofloxacin did actually reduce that risk compared to placebo. So the red line had a sort of lower number of people either having a fever or dying versus the placebo, which is the blue line. But there were some caveats to this. There was no significant difference in deaths due to infection at 12 weeks. And overall, when you looked at 12 months, so 1 year, there was no difference in mortality at 1 year. So although it met its primary endpoint, there were some questions about the effectiveness, basically. And there's been some conclusions, and this is taken from an Australasian group called MSAG, and they've sort of analysed some of the data from this trial, and they found that the levofloxacin group did prevent or had fewer episodes of fever and severe bacterial infection. However, there were more resistant organisms in patients who were treated with the antibiotic levofloxacin. So we know that when we give antibiotics, one of the problems that can happen is that it can select out bugs that are resistant to those antibiotics. And that's what they found here as well. And actually, there appeared to be a higher rate of death due to progressive disease in the levofloxacin group. It's not clear why that is. So actually, they have to be a bit guarded by some of these findings. And the guidance from MSAG says, with the growing threat of multi-drug resistant bacteria, in the absence of a clear mortality benefit, routine antibiotic prevention with fluoroquinolones is not recommended in first-line therapy. So there's some sort of mixed results, really. So moving on to what's called secondary hypogammaglobulinemia, which basically what that means is we know that B cells and myeloma cells in particular make antibodies, the plasma cells, and antibodies are the proteins which help to fight infections, and we all make millions of different antibodies. We know that patients with B cell cancers, often the levels of antibodies can be lower, and that can be due to the underlying disease, also due to the treatments that people are having as well. And we have some guidelines in Australia and New Zealand that in terms of when we can give intravenous immunoglobulin, and that's a preparation from the blood service, so collected from multiple donors, and it's basically giving patients donors immunoglobulin as an infusion, and that's given usually once a month. And there's different guidance. So in Australia and New Zealand, the guidance is a bit different to the UK, and actually in the UK, there's a bit of it's a bit harder to get immunoglobulin compared to in Australia and New Zealand. And we know that the demand for immunoglobulin is going up every year, and you can see that on this graph. Every year, the demand's getting higher. And we don't know, there's a lot of mixed data really on how effective immunoglobulins are, and we need more good data to sort of guide us on that really. So this is a trial called the Rational trial that was performed in Australia and New Zealand and has been published. And this was basically a feasibility trial, and it was looking at patients who were eligible to receive intravenous immunoglobulin. And it was saying, basically randomizing those patients between either giving them immunoglobulin or giving them antibiotics as an alternative. So you can see here that patients were randomized 2-to-1. So 2 patients would get preventative antibiotics and 1 patient would get immunoglobulin. And then there were various outcomes that were looked at, obviously including number of infections over time, and the follow-up took place over 12 months. And again, the characteristics of patients in this pilot trial. So CLL was actually the most common diagnosis. Around 50% of patients had CLL. Patients with myeloma and other type of B-cell lymphomas in there as well. And about a quarter of patients were receiving active treatment at the time of going on the trial. And in a snapshot, really, this sort of summarizes what the outcomes were. And actually, there was a similar proportion of patients with infection in both arms. So the rates of major infection were similar whether you were given antibiotics as a prevention or intravenous immunoglobulin as a monthly infusion. There wasn't a significant difference between them. And in terms of patients remaining on treatment, it was about the same as well. And this was only a small trial, so quite small numbers of patients, but the outcome suggested that it does support the feasibility of a larger phase 2 or phase 3 trial. So we know that immunoglobulin is actually very expensive, and this was some cost-effective analysis taken from the RATIONALE trial. And they actually found that in order to prevent one serious infection, it actually cost about 111,000 Australian dollars. So quite a high cost, actually. And there was some analysis here which is looking at how effective the treatment is versus how costly it is. And you can see that the estimates here were that immunoglobulin is actually less effective than antibiotics, but more expensive. So that's kind of where you don't want to be, really. This would be the area that's saying the immunoglobulin is more effective and less costly. So it's kind of in the opposite area to where you want it to be. So this suggests that there may be some problems in the cost effectiveness of intravenous immunoglobulin. And there's been some big studies looking at analysis of infections in patients with hematological malignancies. This is looking at multiple different trials and trying to combine those results to see how effective these interventions are. This was taken from the meta-analysis, and they looked at around 21 studies. You can see 8 of them were looking at intravenous immunoglobulin, 5 of them were looking at antibiotics, and all of them were in myeloma. 7 were looking at vaccinations. And overall, there were quite a few studies that were taken from quite a long time ago, over 15 years ago. And some of them didn't meet the sort of standards to get into this review as well. So overall, the level of evidence was reasonably weak, actually. And you can see this is the results when they looked at the top graph here is looking at all-cause mortality. So how likely are to die with using immunoglobulin compared to not using immunoglobulin. And you can see that this sort of whisker plot here crosses 1. So that means that basically there's no difference in terms of overall effect on mortality compared to having immunoglobulin versus not having immunoglobulin. So there didn't seem to be a difference in that risk. Looking at risk of one or more clinically documented infection, well, this one here, you can see that the whisker here is below the 1. So that does actually favour immunoglobulin. So these results do show that giving immunoglobulin does seem to reduce the risk of a severe infection, but it doesn't seem to affect the overall survival of patients. So this is a similar plot looking at preventative antibiotics versus not having preventative antibiotics. And again, you can see here it did not reduce the risk of mortality with antibiotics. And it wasn't actually found to reduce the risk of a clinically documented infection as well. But it was noted that, as I say, a lot of these trials were done quite a long time ago. And things have changed in terms of treatment in the current time. So it's hard to know exactly how applicable some of that is, but nevertheless, that's what it found. And this sort of summarizes the results from the meta-analysis, and you can see that immunoglobulin reduces infection, didn't affect survival. Antibiotics was negative on both fronts. And again, vaccinations were shown to have clinically reduced amounts of infections, but again, didn't seem to affect survival from this analysis. So I suppose that means there's no standard for what we do sometimes as well, and different clinicians have different ways of carrying on intravenous immunoglobulin. So some people will carry it on until an adverse event occurs. Other people may have a fixed duration of immunoglobulin, but we don't always know the best way to guide this at the current time. So from this pilot study, there are some more questions that came out, and one of the questions is, what's the effectiveness, safety, and cost effectiveness of preventative antibiotics as an alternative to intravenous immunoglobulin? Can immunoglobulins be stopped after 6 months if patients are free of infection? And for patients receiving immunoglobulin, is a lower dose as good as a higher dose? And there's a new trial which is opening very soon, which is a platform trial, and it depends which indication that patients go into. So the top one, for example, is starting immunoglobulin on those patients who aren't on immunoglobulins now, and they're being randomized again between immunoglobulin and preventative antibiotics. The middle group in orange there is patients who have been on immunoglobulins for 6 months or more and are potentially eligible to stop according to the doctor treating them. And they're being randomized to either stopping immunoglobulin with some emergency antibiotics as backup, or given preventative antibiotics, or continuing immunoglobulin, and trying to see which one is better, or are they equivalent. And then the third one at the bottom in grey is basically randomizing patients between a standard dose of immunoglobulin versus a lower dose of immunoglobulin, again, given every 4 weeks. And then the outcomes of the trial are looking at infections, rates of hospitalization, cost effectiveness, and quality of life as well. And these are the outcomes here for this trial, and the primary outcome is going to be event-free survival, defined as the randomization until earliest date of occurrence of a grade 3 or higher infection. So a grade 3 or higher infection is an infection that is severe enough to need hospital admission, basically. So if you need to go into hospital for an infection, that would be classified as a grade 3 infection. That's correct, yeah, Australia and New Zealand, yeah, and there'll be sites in New Zealand opening for this trial as well. So I'm just going to move on a little bit to a different direction, because many of you will have probably heard of these sort of newer treatments which are coming through to treat conditions like myeloma and lymphoma, which are more immunotherapy-based treatments. And this sort of diagram here depicts a myeloma cell in red. And there are two different sort of broad classes of immune therapy which are coming through at the moment in myeloma and in lymphoma. And you've got CAR T cells, which are basically patients' own immune cells being modified to target the cancer cell. And if you want to hear more about that, I'm doing a talk on that a bit later on today. And then the other type here is it's more of an off-the-shelf treatment, in that these are bispecific antibodies, and you can see that the antibodies bind both to a T cell and also to the myeloma cell or the tumor cell. And what they do is they bring the patient's own T cells into close proximity to the myeloma cell and allow the T cells to attack the myeloma cell. So kind of harnessing the patient's immune system to target the cancer. And this is becoming, more being used a lot more overseas, really, to treat these conditions. And one of the issues that has been highlighted is infection, really. And particularly in myeloma, the target that's being used predominantly for these therapies is called BCMA. BCMA is a molecule that's on the surface of the myeloma cells. And you can see that with the bispecific antibodies, the rates of infection have been really high. And you can see that around 80% of patients treated with this drug called teclistamab, which is a BCMA targeting bispecific, about 80% of these patients had infections, and around 55% had severe infections, which is quite a high number. And these are infections that would need hospital treatment. This is more data looking at this drug called teclistamab, which is the BCMA bispecific. And you can see here, again, as I say, 80% of patients having an infection, grade 3 or above infection in over half, 55% of patients. Predominantly respiratory infections, pneumonias, have been a big problem. And you can see also COVID-19 infection. I think this trial started at the time when the COVID-19 pandemic was taking off, and unfortunately there were a proportion of patients that died from COVID-19 infection in this trial. But this was nevertheless a signal that's been picked up with this type of treatment. And this is quite interesting. It's looking at basically the response to the COVID-19 vaccine in patients who are receiving these BCMA bispecific antibodies. And you can see that the red basically refers to the antibody response from the patients who are receiving the BCMA bispecifics. And the green bars represent patients who are on different sorts of bispecifics. So, for example, in lymphoma, there are different targets used. So the actual drug is different compared to the one used in myeloma that targets BCMA. And you can see that the response of the vaccine is much less actually, when you're looking at the BCMA in red compared to the other bispecifics in green. So for some reason, those patients aren't able to mount a good immune response to the vaccine in patients who are on these BCMA bispecifics. And this is, again, looking at patients on these BCMA bispecifics. And you can see the graph here on the left-hand side. This is the first bar. So this bar is basically at baseline. And this is measuring the amount of immunoglobulin, so functional immunoglobulin in the patient. And you can see that over time, so each bar is a new month down the line, the immunoglobulins get less as time goes on. And after you get to about 6 months, really all patients have a very low immunoglobulin level, and that will predispose them to infection. And you can see this graph here, as time goes on, the probability of infection gets higher and higher with these treatments. So this graph on the right side basically looks at giving immunoglobulin prevention in these patients. And you can see that the green bar represents patients who weren't given immunoglobulin, whereas the orange bar represents those that were given immunoglobulin. And you can see that the rates of infection were much lower if you were given the immunoglobulin compared to if you weren't and you were observed. So in this particular group of treatments, it does look like immunoglobulin replacement is really important because we see the outcomes are much better if you give immunoglobulin. And that's because these treatments are really immunosuppressive. They're very good treatments, but they do suppress the immune system a lot. And actually, as I mentioned before, different bispecific antibodies that are used, for example, in lymphomas, don't seem to have as much in the way of this immunosuppressive effect. And you can see only around 6% of patients with this different type of bispecific drug were getting low immunoglobulin levels compared to virtually everyone in the myeloma BCMA group. So I'm just going to move on to a case presentation from a patient in Wellington. This was a 51-year-old lady who presented in November 2022, basically presented with renal failure, so kidney impairment, and she had a background of having type 2 diabetes, high blood pressure, and previous exposure to hepatitis B. She was diagnosed as having light chain myeloma, and she had very, very high light chains in the blood, over 10,000, apologies, which is a really high level of these light chains, which is a type of myeloma that we see. And she had, in her bone marrow, she had a high number of the abnormal plasma cells, the myeloma cells. And she had some genetic changes in the myeloma cells that meant that the condition is higher risk, so it's harder to treat because of this mutation called the TP53 deletion. So she was treated with what was the sort of standard treatment in New Zealand at the time, which is called Cybordex, cyclophosphamide, bortezomib, and dexamethasone. She was given prevention with valacyclovir to reduce the risk of shingles, and entecavir, which lowers the risk of hepatitis B reactivation. But her light chains only reduced quite modestly over the first 6 weeks, so from about 10,000 down to 5,000, so not a particularly good response to treatment. After 4 cycles of treatment, so 4 months of treatment, the light chains were static. They hadn't really come down, so the myeloma wasn't responding, unfortunately. So she was switched on to a more intensive treatment called VTD PACE. Again, unfortunately, there was no response with the treatment. Then lenalidomide was added on in addition to the intensive chemotherapy. And at this time, she had a few superficial skin infections, but was otherwise well. But again, the myeloma didn't respond, unfortunately. So then she was basically refractory or not responding to 3 lines of treatment, including lenalidomide. And we were lucky enough to have the Magnetism 5 open in Wellington at the time, which was a clinical trial which randomized patients to different drugs, and some of them were getting a drug called elranatamab, which is a bispecific BCMA antibody, which we looked at in the last few slides. And also patients would have daratumumab in as well. And so she was randomized to receive both the BCMA antibody and daratumumab. Had a first dose of elranatamab, which is the BCMA bispecific, in June. That was 2023. She developed a few expected complications, something called cytokine release syndrome, which is a bit like an inflammatory response, really. But she responded to that and had further doses of the elranatamab. She then was admitted to hospital with shortness of breath, cough and fever. She was found to be influenza A positive. Her neutrophil count was normal. She was given Tamiflu, an antiviral against influenza, and also intravenous antibiotics. She had a sort of partial recovery, but was then admitted after being discharged, came back into hospital 5 days later with persistent symptoms and thought to be a protracted influenza infection. At this time, it was found that her immunoglobulin levels were quite low at 3.9. So at that time, she was started on intravenous immunoglobulin replacement. And since then, she's done really well, actually, and she's been on the immunoglobulin every month since then. She's only had 1 day in hospital since that time with a suspected viral illness, but was clinically otherwise well. You can see here that this is the immunoglobulin levels in that patient, and you can see this was at diagnosis, so they are reasonably low at diagnosis, but this is when she started the bispecific antibody elranatamab, and you can see the levels really dropped down quickly once she had the drug, which is in keeping with what we were saying earlier on in terms of these drugs really suppress the immunoglobulin levels. And then, she went on to immunoglobulin replacement every month, and the levels were maintained at a more steady level, and she was clearly free of infection during that time as well, so did well. And you can see here that this is the graph of the light chains, which is a marker of the myeloma, really. And you can see that throughout the first few treatments, the light chains remained high. They were still around 5,000. But when she received the elranatamab and then daratumumab, the light chains really plummeted down, indicating a really good response to the treatment. And thankfully, they've remained very low since treatment. And she remains on this treatment with elranatamab and daratumumab and is doing very well. So in response to these sort of low immunoglobulins and signals of infection on this trial, there's actually some safety signals that came out, and it was recognized that there were high numbers of patients, unfortunately, having severe infections that led to death as well. And there were some recommendations that came out from that. So very clear guidance about ensuring that patients who had signs of infection didn't receive the treatment and had it deferred. And also guidance about using preventative medication, so antibiotics to prevent infections such as pneumocystis, antiviral medications, and also immunoglobulin replacement early on in treatment. And that was mandated on this trial because of the high rates of infection. So I'm just going to move on to vaccinations now as well. So I've just picked a few different vaccinations to focus on. Firstly, pneumococcal vaccination. And there are two different sort of types of pneumococcal vaccine. So pneumococcus is a bacteria that can commonly cause pneumonia. And we know that patients who are vaccinated with the conjugate vaccine called the PCV13 or the Pneumovax vaccine can be protected against pneumococcal infection. And it's been shown that if you give the polysaccharide, the Pneumovax vaccine, at least 30 days later than or after the pneumococcal conjugate vaccine, that has the best sort of outcomes. Interestingly, patients who are on drugs like lenalidomide, that can actually improve the antibody response and cellular response to these vaccines. So patients who, for example, are on lenalidomide maintenance therapy, potentially that could be a good time to get vaccinated against these, with these vaccines, sorry. And in New Zealand, the current sort of funding for these vaccines, so the pneumococcal conjugate vaccine, the PCV13, patients who are post-hematopoietic stem cell transplant or pre and post chemotherapy, and for the PPV23, patients who are post stem cell transplant or post chemotherapy. And you can see that the MSAG guidance in Australia as well is that the vaccine should be the PCV13 followed by the PPV23 by at least 2 months, and also trying to vaccinate before treatment or during treatment with IMiDs like lenalidomide. Moving on to COVID vaccination briefly. This is the current broadly used vaccine in New Zealand for COVID-19, which is an mRNA vaccine which has activity against the Omicron variant of COVID-19. And you can see that the guidance in Australasia is that patients should have at least 2 doses of this vaccine initially. And response rates actually generally are good for most of the treatments that we use in myeloma, for example. And this is some guidance from the New Zealand Immunisation Advisory Centre. This are basically patients with blood cancers would be classified as at high risk of infection from COVID-19. And therefore a primary course of 3 doses 8 weeks apart is recommended. And then usually the next dose should be given 6 months after a previous dose or prior infection, but it can be reduced down to 3 months on a case-by-case basis as well. Okay, and then briefly, so herpes zoster, so shingles. Shingrix vaccine is a recombinant vaccine which is now funded in New Zealand from the 1st of July for all patients 18 years and over with hematological malignancies. And 2 doses can be given, second dose 2 to 6 months after the first. This was a clinical trial that was published a few years ago, looking at this vaccine after an autologous stem cell transplant. And you can see patients were randomized between either 2 doses of the vaccine versus placebo. It was given 50 to 70 days after the stem cell transplant. And the primary endpoint was looking at the occurrence of herpes zoster or shingles cases. And actually the vaccine significantly reduced the risk of herpes infection. You can see it on this graph here. So the incidence of shingles was much lower with patients who had the vaccine versus patients that didn't have the vaccine in the placebo. So effective vaccination. So I'm just going to very briefly move on to watch and wait, but it might be a good time to have some questions, but I'm happy to go through the watch and wait slides now as well.
Have ibrutinib and been having it for 3.5 years, and I have complete blood counts once a month. None of those, all those counts are basically in the normal range, and I do a lot of outside work, so I come in with scratches from roses, blackberry, using an axe, using a chainsaw, and they all seem to heal all right. When I go into the CLL websites, they say don't prune roses, don't go outside. If you get a little cut or abrasion, worry about it.
Yeah.
But I mean, I just see mine heal. And so what's the story?
Yeah, I mean, it's a very good question. And I think it does differ between different individuals. And clearly, you know, you're managing those symptoms really well by the sounds of things. I think the key thing I would say is being vigilant. And if something looks like it's getting more infected, getting redder, or if you have any other symptoms such as a fever, really having a low threshold to seek medical attention to get antibiotics. So really treat things more aggressively than you would have done before you were diagnosed with CLL on ibrutinib. I think, you know, drugs like ibrutinib can be really, really effective at giving people an excellent quality of life. And I think if you're able to do those things, that's great. And I think just being cautious and obviously using protective equipment where necessary, gloves, things like that is really important. Maybe a mask if you're around soil, that sort of thing would be sensible. But you've still got to live, you know, your life in the way that you want to. And I think just being sensible is appropriate. And obviously speaking to your doctor about that as well. But I think, yeah, being vigilant is one of the key things, and being vaccinated with the up-to-date guidance would be helpful as well, I think. Yeah. Right.
Thanks. I was looking at the bispecifics and wondering why there's an increased rate of infection. And I was wondering whether it's because it commits the T cells to the, I'm assuming the C38 receptor on the myeloma cell, and whether once it drags in the T cells, they are not in a position to fight the other infections, or is there some other mechanic at play?
It's a good thought, actually. I think a large component of the high infection risk comes down to the fact that, as well as targeting the myeloma cells, the bispecifics are targeting your healthy plasma cells that make immunoglobulins, and therefore you're not able to make the immunoglobulins when you're on the bispecifics. So they're very low, and I think that's probably a large part, but there may well be other areas, and there may well be some reduction, as you say, in the T cell response as well, but that's a really good question. I think the data is quite strong in terms of low immunoglobulin levels and antibody levels. In terms of T cell responses, that's a really good question. I'll have to look at that, actually. Yeah, it's a good thought.
Is it necessary, would it be important to have dental treatment for very low grade inflammation? Is dental inflammation a risk at all levels?
Yeah, I mean, I think it is in terms of. I think, yeah, oral hygiene obviously is really important, and we know that patients who have, for example, low neutrophil count, the healthy white cells, patients who are going through chemotherapy, when the neutrophils drop, we know that dental infections can be a real problem there. So sometimes, if patients do get severe dental infections, we do actually recommend, you know, certainly a dental review, sometimes teeth extraction, for example. We tend to recommend it more in between chemotherapy. So if a patient has got good neutrophil counts in between chemotherapy, that's a better time to have a dental procedure than if you're going through chemotherapy and your blood counts are really low. Occasionally, or sometimes you might have to do that if a patient's very unwell. But certainly seeing a dentist before you have treatment is a really good thing, and making sure that your dental health is as good as possible, because you're right, it is a source of infection, definitely.
Do you feel that having the shingles virus with CLL's safe? Just I'd heard advice that having a live virus, a live vaccination, with CLL isn't recommended.
So that's a really good question. So absolutely, a live vaccine isn't recommended. The Shingrix vaccine is actually not a live vaccine. So the previous vaccine that was used, called the Zostavax, was a live vaccine, which was not recommended. But the Shingrix vaccine is not a live vaccine, so that would be recommended. So the Shingrix is now funded as well, so definitely would recommend it. I don't think it is, but I'm not 100% sure. I don't know if Ian, would you know that? No, I don't think it is.
Yeah, hi Philip, thanks very much. The case study that you put up with I think she was a 51-year-old lady, where she'd gone through the standard treatment for myeloma,
Yep.
myeloma, and then towards the end there she had the combination of daratumumab, and there was the other one, the other drug,
Elratanab, yeah.
Elratanab.
That's right.
So with the standard treatment, obviously she went through quite a lot as she responded to those drugs, but
Yeah.
once she had the combination, the infection rate decreased severely. So is that an indication that perhaps we should start the treatment on the two drugs? Is there any study that shows significantly that's a good starting point?
To use it earlier on in the
Yeah.
treatment. Yeah, I think that's, definitely that's a really good point. And as these treatments come through over time, they're definitely being used earlier on in treatment, because the idea is that patients who are treated earlier, their immune systems are stronger in general, and therefore the effectiveness of these treatments may well be better earlier on than later, and potentially risk of infection could be better earlier as well, but that's probably not proven, I would say. But I think generally the way that new treatments work are coming in a bit later down the line to see how they work compared to the standard treatments. And then if we see they're doing well and they're effective, then they can be brought earlier on in the treatment. And we're still at the stage, in general, they're still a bit later in the treatment, but there are trials now where they're bringing either bispecifics or CAR T-cell therapy earlier on in the treatment. And I think outcomes are better, as you say, if you're given earlier. So, yeah.
Just with infection, open wounds and things like that, I was given antibiotics, though there was no sign of infection at present. Is it best to start antibiotics before any sign of infection? Yeah,
so I think that's a good point. And I think if we think that someone or a patient is at risk of a severe infection or their immune systems are low, often we do have a very low threshold to give antibiotics. So we would often give antibiotics early to try and prevent severe infection rather than wait till they potentially get a bit worse. So I think we do have we will treat things earlier, infections earlier in patients who are on immunosuppressive treatments with blood cancers compared to if you weren't on those. So I think it's definitely better to be on the conservative, on the safer side in that way. That's my personal feeling, and that's I think how a lot of people will practice in general.
More questions? If anyone has any?
I could just go through the watch and wait briefly. So I think there was a question before the session about watch and wait and sort of active monitoring, really. So just using CLL as an example. So in CLL, we know that when patients present with CLL, a number of patients don't actually benefit or need treatment earlier on in their diagnosis and can be safely monitored rather than actively treating. And these are some of the indications for treatment in CLL, which are standardly used. So patients who are anemic or have low platelet counts, if you have very enlarged lymph glands or symptomatic lymph glands or big spleens that are causing symptoms. B symptoms, so fevers, night sweats, weight loss, etc. These are all reasons for treating CLL, but there are many patients with CLL where actually things are very stable, the blood counts look stable, they're not having significant symptoms. And actually in these patients, it's recommended to actively monitor the condition rather than actually treat the condition early on. And that's sort of, similar thing that we were just saying, really. This is some data looking at patients treated with either FCR or watch and wait. And patients were divided into different groups. And the green group was what's thought to be low-risk patients. These were patients who had no high-risk genetic features in their CLL, for example, and were asymptomatic. And then we had the high-risk group of patients who were still asymptomatic and not requiring treatment by standard criteria, but they had high-risk features, for example, high-risk genetic features. And you can see that these patients were randomized between FCR, which is a chemotherapy treatment, versus watch and wait. And unsurprisingly, patients who were treated with FCR had less progression of the disease compared to those who had high-risk watch and wait. But that's not surprising because you're giving a treatment that's going to prevent progression. But actually, when you looked at the survival in these patients, they were the same. So whether you got treatment or whether you were watched and monitored had the same outcomes in terms of survival. So, waiting a bit later potentially doesn't cause any overall change or adverse effect. Ibrutinib, again, you can see avoiding some of the adverse effects with ibrutinib compared to placebo. So potentially some unnecessary adverse effects in patients that may not need treatment with similar outcomes. And we have guidance for GPs. We have 3D health pathways with clear guidance for how to monitor, for example, CLL, what to look out for, when to repeat those blood tests, some advice about vaccinations as well. Again, clear guidance about when to refer patients to haematology as well. So I think, it's important we have close interaction with GPs, and particularly in these sorts of conditions. And there's some very good advice from LBC as well on active monitoring, because it can understandably be pretty anxiety-provoking for some patients, but it is definitely an important part of management in some patients.
Thank you.